Good afternoon for Israeli. Good morning for the people from US and Brazil and the other part of the ocean. And good evening for the Indian people who are joining us. We are launching today the first event of the hot summer in drug safety. And we are very excited to launch this series of events that will be every week during 1 month till 5th of August. And in the middle of the month, in the 15th of June, we will have a special event with an online summit, inaugural online summit with Motherisk International, drug safety in the COVID era. And we know how many issues we have encountered. And it will be chaired by Professor Gideon Koren, who is with us today, and with a special guest, Peter Pitts. Both of them are part of our advisory board and scientific committee, same than Ronan Lobstein, Professor Ronan Lobstein, head of the Department of Pharmacology and toxicology, who will present the first case. And so if you think that safe medication matters, that safe patient matters, so join us for the rest of the hot summer. Please, Ronan, go on.
Okay. Okay, do you see the screen?
Yes.
Yes.
Yes, we do.
Okay, good. So I'd like to share with you a problem that we are facing both in the hospital and in the HMOs, which has to do with the treatment of direct oral anticoagulants, drugs that are gaining more and more popularity over the last years. And those drugs were presented to us as drugs with predicted dose-effect relationship, which means that one dose should fit all according to the manufacturer, with no need to monitor the anticoagulant activity. And in reality, we are facing more and more problems dealing with the variability of the response to the direct oral anticoagulants, many of which have to do with drug-drug interactions with those medications. So I wanted to share with you a case that we had, one of many cases that we faced in our hospital, and this was a 70-year-old patient with a past medical history of generalized tonic-clonic epilepsy, hypertension, a history of transient ischemic attack which was manifested by amaurosis thorax about 6 years ago, who suffers also from chronic atrial fibrillation, for which he was treated with anticoagulation. The medications of this patient included phenytoin with a daily dose of 300 milligrams, carbamazepine with a daily dose of 900 milligrams, bisoprolol with a daily dose of 10 milligrams, and amlodipine with a daily dose of 10 milligrams. And he was routinely treated with warfarin with an average weekly dose of 42.5 milligrams per week to a target INR of between 2 and 3. And he was well controlled over the years with this dose. About 4 years ago, with the increasing popularity of the direct oral anticoagulant, his cardiologist suggested to switch his anticoagulant treatment from warfarin to dabigatran, which is a direct thrombin inhibitor. And he was started on dabigatran with the recommended dose. He had normal renal function at that time, and he was started in the recommended dose of 150 milligram twice daily. After being well controlled with the epilepsy and with the anticoagulation treatment over the years, about 3 months after the initiation of dabigatran treatment, this patient experienced a transient ischemic attack, which was manifested by a transient left hemiparesis. And about 7 months after the initiation, another transient ischemic attack appeared. This time it was manifested by dizziness, which was summarized as a vertebrobasilar transient ischemic attack. Nothing was done with, at this point, after those 2 transient ischemic attack, with either with his anti-epileptic treatment nor with his anticoagulant treatment, and he was continued with dabigatran 150 milligram twice daily. And it was about 1 year after the initiation of dabigatran treatment that he experienced a major stroke, after which he was left with left hemiplegia. At this point, the neurology department decided to involve a clinical pharmacologist who suggested that there might be an under-treatment of the anticoagulant treatment with dabigatran due to drug-drug interaction. And trying to prove this point, he took two lab tests. One was thrombotic time, which showed 13 seconds, and I will discuss it in a minute. And he took also dabigatran plasma concentrations, which revealed 28 nanograms per milliliter. Now, going a little bit through the medications of the new oral anticoagulants, we can learn that drug-drug interactions are not surprising at this, with these medications. As you can see, dabigatran is a substrate for P-glycoprotein, and the two other 10A inhibitors, rivaroxaban and apixaban, are substrates for both P-glycoprotein and cytochrome P450 CYP3A4. So if we're looking on, in our case, in dabigatran only, this drug is, the bioavailability of this drug is heavily regulated by the activity of P-glycoprotein, and therefore any drug that will interfere with the activity of P-glycoprotein, either by inhibiting the activity of P-glycoprotein or alternatively by inducing the activity of P-glycoprotein, will affect the bioavailability of dabigatran. And this is exactly what happened in our case. If you're looking about the main inhibitors and inducers of P-glycoprotein, you can see that among the inducers, you will find also carbamazepine and phenytoin, both drugs that the patient had received. So this patient had really a major impact of induction on P-glycoprotein activity, which resulted in decreased bioavailability of dabigatran. And this was well proved by the two lab tests that were taken after the major stroke. The first one being the thrombin time, which is a very sensitive marker for antithrombin activity. And in this case, 13 seconds is normal, meaning that there is no antithrombin activity at all. And this again, to prove this point even further, blood concentrations were taken, and 28 nanograms per ml that were found are extremely low concentrations of dabigatran, which is usually between the therapeutic range of 50 to 200, 15 being the lower normal range. So what happened in this patient is basically the co-administration of carbamazepine and phenytoin, which had a major impact on PGP induction, resulted in extremely low bioavailability of dabigatran. And in fact, the 150 milligrams taken twice daily basically resulted in extremely low plasma concentration of the anticoagulant, and hence an absent anticoagulant activity at all, which resulted, as you can see clinically, in two TIAs and another major stroke. If you're looking on the entire picture of drugs that potentially will affect the direct oral anticoagulant, there's an increasing list of medications that will affect either PGP and therefore will affect dabigatran, but there's also other drugs that will affect also PGP and P450 cytochrome with the 3A4 isoform, which will affect also the metabolism and the bioavailability of the 10A inhibitors, rivaroxaban and apixaban. And there's an increasing list which is available all around to see what are the potential medications that one should avoid while treating with dabigatran or rivaroxaban or apixaban. So taken together, what we can learn about this case. First of all, for the prescriber, you have to be aware for potential drug-drug interactions with direct oral anticoagulants. These drugs are not prescribe and forget as they were marketed. You cannot prescribe the drug, say to yourself and to the patient, there's no need to monitor anticoagulation, and let the patient go with the anticoagulant forever. We have to know that there are potential important drug-drug interactions that will affect anticoagulation to both ways, either under anticoagulation or over anticoagulation. We think that we need to use clinical decision support system to bring alerts about those potential drug-drug interactions. We know that many hospitals and HMO use nowadays computerized clinical decision support system, and this is an important tool to access the data about potential drug-drug interactions with the direct oral anticoagulants. In cases where you have multiple drugs with potential interaction with the direct oral anticoagulants, you can still consider the alternatives of anticoagulants. We can still go back to old good warfarin, in which we monitor the anticoagulant activity by measuring periodically INRs, or we can go to low molecular weight heparins, which again are more predicted and suffer less from those drug-drug interaction. And in very complicated patients in which we decide to continue with direct oral anticoagulants, we can measure the anticoagulant activity or plasma drug levels. We have now plasma drug levels for dabigatran, apixaban, and rivaroxaban, and we can monitor the anticoagulant activity. If we are treating with antithrombin inhibitors, we can measure thrombin time, and if we are treating with direct 10A inhibitors, we can measure 10A activity. I think also for the industry and the HMOs, it's important to provide updated information about drug-drug interaction, again, either in the leaflets of the drugs or to incorporate the data into clinical decision support system. That's it.
Thank you so much. I just wanted to ask if how you are using Medaware, for instance, that you are using in Shiba. How you are using it to prevent this to happen? Is it something which is always working, or it's not always?
Unfortunately, Medaware at this point does not contain a model for drug-drug interactions. It only alters on indications and inappropriate doses. We have another clinical decision support system, which is called SaferX, which provides drug-drug interaction alerts, but this system provides too many alerts because this is a rule-based clinical decision support system. And as with many other clinical decision support system, it suffers from alert fatigue. So what we are trying to do right now is really to develop a smart AI drug-drug interaction module with Medaware, hoping to really incorporate the data about potential drug-drug interactions with other drugs as well, but with direct oral anticoagulants as well, because we feel that this is a neglected area where physicians are not aware of the potential interactions and the consequences.
Yes, and especially that drug-drug interaction, it's not only between two drugs, but it could be between three drugs. So it's too complicated now for the prescriber to handle all this. Do we have any questions from the participant? Somebody is just mentioning the OTC, that we have also a drug interaction with, or interaction with OTC, and we can say also with food.
Again, I think this should be incorporated into clinical decision support system, and at least to access the data to the treating physician and let him judge if he wants to treat with this potential interaction or not.
Okay, so do we have any questions from the participant? No, so thank you very much, Ronen, and we will now go to the second lecture, my lecture, about Lyell syndrome. So I will see if I have the screen. Do you want to continue? Escape. Gad, I can open my.
Yes,
I can share my screen.
Sure.
Okay. Okay, so I will do that. Okay. I'm lost. Okay. Share my screen. Okay. We will now speak about another problem with drug. In fact, we are here to speak only about problems, unfortunately. And I wanted to speak about the bullous toxiderma, because first of all, I had a friend who died from that. And but not only, but also because I was involved in risk prevention with allopurinol. So the case is as the following: it's a 72 years old woman hospitalized in a burn unit for Lyell syndrome. 5 days before the hospitalization, she had a flu-like symptoms. Red macules on trunk and arm. And 2 days before the hospitalization, apparition of bulla and hemorrhagic blisters. She was treated with fluids, enoxaparin, pantoprazole, and morphine, and eventually immunoglobulin because her state was worsening. We had a very rapid evolution of 50% of total body with hemorrhagic lesion, and the mortality rate, as usual in the Lyell syndrome, was very high, with 58% assessed as 58%. Fortunately, this patient improved within 10 days. She had to be in the plastic surgery for the debridement of the skin, and eventually she was discharged from hospital on the 35th day. Her medical history was hyperuricemia with clinical symptoms, without clinical symptoms, and she was treated with allopurinol, 300 milligrams per day, and it was started 10 days before hospitalization. She had also high blood pressure, treated with losartan hydrochlorothiazide, and she had a renal function with a clearance of the creatinine clearance of 50 millimeter per minute and GFR of 72 milliliter per minute. So, what we have to say about that? First of all, if we take again the same story, we can see that it has taken 5 days for this patient to come to the hospital, and the drug was not withdrawn before these 5 days. And we know very well that the delay in the diagnosis and the delay in stopping the drug is very important for the prognosis of and the mortality rate. Then we have this indication, and the problem is that there is no indication of treatment when we don't have clinical symptoms. The allopurinol must be only used when we have symptomatic hyperuricemia. And then we have this problem of the renal function. In the SMPC of the drug, we know that we should start with 100 milligrams and then go up and up very carefully, and it should be adapted to the renal function. And for a patient 72 years old, we know that renal function was not so good, and so we have to adapt. And for this level of creatinine clearance, the maximum that we should use is 200 milligrams. So in fact, this case was a very obvious case of misuse, because this woman should not have been treated. So this case is coming from the French agency, which has performed a cases review of all the Steven Johnson and Lyell. The first cause of Steven Johnson, Lyell syndrome, and Dray syndrome is the allopurinol in Europe and in Israel. On 96 cases, we saw that the mean delay of apparition after using the drug was about 26 days, but we know that even after 1 year of treatment, we can see the Lyell or the Steven Johnson. The mean drug withdrawal is 6.5 days, plus minus 7 days. And this is a big problem, because we know that during this time, the mortality rate is growing and growing. So the mortality rate was up to almost 50% in the Lyell and the Steven Johnson in this case review. Generally speaking, for this review, which was made by the Pharmacovigilance Center of Lyon, it was about 1 case for this new treatment. And in the literature, the incidence in allopurinol patients is 0.4%. And when we know how much it's prescribed, it's not so low. And if we look at per million of inhabitants, meaning also people who are not ill, it's 1 to 2 million. So what are the risk factors? The female are more prone to have a Lyell. The dose is a very important risk factor. So it's why they have asked the SMPC to be changed and to oblige everybody to adapt from 100 milligram and not to start from 200 or 300 milligram. And we have found that HLA-B 5801 was also a risk factor. This was from a Chinese paper. The problem is really the fact that there is not enough awareness, not among the healthcare professionals, not among the patients about the risk. And very recently, I had a friend who showed me her treatment, and she had a drug with a risk, even if the risk is very low, with a risk of Lyell. So I told her, if you have any little scare, something rash or red spot on the skin, you stop immediately and you go to your doctor. So this lack of awareness is delaying the diagnosis and the drug withdrawal, which is increasing the severity and the mortality rate. The misuse is very, very frequent in this with allopurinol, especially with asymptomatic hyperuricemia. So this is coming from Lyon Pharmacovigilance Center, and I have found also Israeli paper saying that the most common cause of Steven Johnson and Lyell syndrome in Europe and Israel is allopurinol. So a very common drug. So these are the references that you will have when you will go to my presentation. So what do we do to minimize this risk? First of all, the prescriber and the pharmacist. To be aware of 100 to 200 drugs causing Steven Johnson and Lyell. Someone told me, but we cannot remember all this. But we can remember some of them, which are used very frequently. We have to check the renal function for allopurinol. And these are the drugs that are one of the causes of the Steven Johnson and the Lion. And you can see that we have anticonvulsivant, we have antibiotics, we have HIV treatment. So meaning that they are not drugs that are used very rarely. So we have to increase the awareness for not only one drug specifically, but at least to this aspect of the drug-induced Steven Johnson and Lion. We could think about prescription and dispensation pop-up reminders, and we know that the problem is of alert fatigue. I think that what we have to say when we have this pop-up is just to tell the patient, so that the pharmacist and the prescriber could tell the patient that they have to stop the drug immediately at the first dermatologic lesion and to consult. It's a very simple sentence. It's not something which will alert so much the patient that he will be afraid to take the drug, but we have to tell them to stop the drug. For the industry, they have to train the sales representatives so that this is something that we have to stop. They have to train the healthcare professional and to make a sensitization actions through the internet and social media, leaflet, conferences. We can organize severe conference about severe acute cutaneous reaction, and that will not point the finger at one drug or another drug, just to have an awareness about that. And of course, you have this black box in the patient leaflet and the SMPC. The HMO Petroleum Hospital, they have to use prescription software and AE solutions, but we have seen that we have some limits about that, but we have to have at the prescription, at the dispensation steps, just to have a pop-up and saying, just tell your patient that he has to stop if he has some skin lesion. And perhaps to be able to detect the first symptoms when we are with artificial intelligence in the electronic medical records, when we know how much important it is to detect the first symptoms. To have some sensitization events and infographics, because this is working much more than a lot of words. For the authority, what I propose is to use the obligatory use of pictograms and infographics on packaging, and to have also an information on website information. And we have some very good examples of pictograms that are working very well, which are these ones. For instance, not to take when you are pregnant, or the black triangle that is used in Europe to tell patients that they have to read very well the patient leaflet. In the academy, of course, we have to highlight and to have a special session about that in the studies, and also to have continuous education. I had some input from Gideon, who is the CEO of Medaware, who is providing artificial intelligence solution. And what he said is that we have, because this is so rare, it's difficult to be to tell the physician all the time, because we will have fatigue alert. So what he said that for the physician, the AE system could identify new rash in the note of the physician. He can also make a check with the rash and with the fact that there is some current or recent drug that have been initiated, and then he could set up an alert if he thinks that there is a suspect drug for Steven Johnson and Lion. For the patient, he has suggested that we could have a smart application that could identify new prescription at risk and ask during 1 or 2 weeks about rash or fever or flu-like symptoms. I would be very glad to have a discussion with you about all this action proposal. And I think that we have one message for all the drugs that, not for all the drugs, but for the drug that can be stopped, which is tell the patient to stop the drug immediately. And it can change so much the prognosis, and it can change so much that it's a very simple message. Because we know that some drugs we cannot stop, and some drugs we must stop. So it's a very easy message, which is not frightening for the patient. What I propose also is that to set up our, it's not something which is specific for the Lyell or Stephen Johnson, but this is something which is increasing the awareness of drug safety in the hospital and in the community, which is our strategy. And our strategy is multidisciplinary. It's we are making projects with healthcare professionals, hospital community, Ministry of Health, Kupot Rolim, HMOs, academy, industry, and we are really centered on the patient. And we have created a really an ecosystem to integrate all these people in the drug safety implementation. And what we are doing is education, for patients, for the healthcare professional. We are assessing the practices in the hospital. We are improving the quality. We are doing some risk management, prevention action, and we have developed tools and methods and right now implementing artificial intelligence tools in our strategy. So please come with us, present your case in Tell Us a Safety Story. We have a 1 month full with every week an event, but we are resuming our activity in September. So you can send us a proposal to speak and share your cases. Don't forget to register to the Hot Summer in Drug Safety, which is every week at 4 p.m. 15th of July, we have a drug safety in the COVID era, the inaugural summit with Motherisk International, chaired by Professor Gideon Koren, and with a special guest, Peter Pist. And we have, every week, we have a meeting. So come, join us, and thank you so much. So, do you have questions or comments about the proposal that I have made, about the action I've proposed?
Irene, this is Peter. Nice presentation. Thank you.
Thank you. Thank you so much.
I posted on the chat a brief article on AI issues. I think an important note to make is, since many of these reporting systems are full of noise, we have to use technology to allow human beings to do the thinking work and allow machine learning to do everything else, rather than hiring more people, which none of us can do.
So we know how much a fan of AI you are, so do I. So, but we still have this fatigue alert, and this is something I know that with Medaware we have less fatigue alert. Medaware is an Israeli company which is now in US and working with Harvard, and which has implemented its solution in Shiba and in many other hospitals. But I know that this will be the next step will be to have this noise, to lessen this noise.
Right. It makes it more accurate and ultimately less expensive.
Yes. The idea is, I wanted to ask all of you the fact that Gideon came back to me and told me, but you know, to have some big action for very small incidents, is it something that that is possible? It's not exactly the way he put it, but it was the meaning of what he was saying. And I would like to have your input. Gidi, what do you think about that? Gidi, you have to unmute you.
Do you hear me now?
Yes.
Yeah, I share Gidi Stein's hesitation. Things about, we were taught in medical school that the most important thing about rare things is that they are rare. And of course, the question is, because mechanistically we do not know yet the mechanisms of all those. And still, even with the example you gave, the number of events is lethal as they are is extremely low. I think AI may be a good idea to try to sort out some new variables that we should think about. But I wonder, as you said, Steven Johnson's is caused by over 100 drugs. There are some leading drugs and so on. But whether telling a physician to be aware and be afraid of a drug because in 0.4% there will be a tragedy because of fatigue, et al, and so on. I don't know that we still have a solution. So I think we have to be very careful before we come up with a program to tell people how to deal with very rare things if we don't have the example you gave about GFR. The GFR of this particular gentleman, I believe it was, or a lady,
Lady.
woman, was not very low. And
No.
And I'm quite sure that for her physician, it was within the normal range and probably she did okay. The second thing you said, I'm just using your example, that you need to treat hyperuricemia only if it's symptomatic. Not always the symptoms are very clear and of hyperuricemia beyond the laboratory. So here is an example. What should he do? How any of our discussions will move his or her decision making, and I'm not so sure. That's my main issue, not just with this example, but any idiosyncratic, rare condition where we didn't sort out yet genetic marker, biological marker that have high sensitivity and specificity. Unfortunately, all we know is that they are rare and probably will publish.
And very severe.
And you know, the example you gave of stopping the drug as soon as you can, but of course, if a patient is on 3 or 4 or 5 drugs and he or she begin to have some rash, this is not an easy clinical decision to stop. And would you stop?
And to consult immediately.
Yeah, I understand. But I said,
Irene?
Yes?
Hi, Hirschman. Just a comment. One, I think that the notion that in medical education, informing somebody or informing the practitioner that something is rare and therefore not necessarily something to focus on, I think is not really the point. I think one of the issues here is that we don't know from the presentation who this patient contacted when the rash occurred. Did they contact the physician or did they contact the hospital? When she developed the rash, did she show up to the hospital or did she contact her doctor who said go to the hospital? We don't know what that interaction was.
Yes, in fact, it was not, we don't have this information.
Right, so that's my point. My point here is that I disagree that something being rare is something that we necessarily put low on our list. I think things that are potentially fatal should be high up on our list, even if they're rare. The only issue here is that if we don't know if the physician knew what to do with this. If the physician got a call from the patient and said, you know, you started me on this medication 2 weeks ago and I'm getting these bumps on my skin, what should I do? Certainly patients who contact the physician and the physician knows that there's potential for some kind of rash with what they gave is a lot better than assuming that something's rare and we just really don't need to focus on it. But the other issue is that if the patient contacts the physician and the physician is unsure as to whether it's their medication or not, I guess going through the list of medications with the patient and what was started most recently and trying to get a picture as to whether it's something they've been on for 30 years or something that they just started 2 weeks ago, again, and stratifying it in that way. But without the piece of information as to how this patient came to medical attention, it's very hard for us to make any kind of prognostication. Artificial intelligence can tell us that rashes can be caused in such and such drugs, and this patient may be on 1 or 2 or 5 of them. So we don't know. That has its obvious limitations. Pop-up warnings, as you said, fatigue everybody, and they just simply click past them and get ignored. So that's the issue. We need to know where the patient contacted the medical system here. Then we can focus on what to implement.
Thank you, Ash. And I wanted to ask you about all of you about the idea of the pictogram, because I think that we could find a pictogram that will not be only for the severe cutaneous reaction, but also to any reaction where to stop the drug will be a key of key importance for the prognosis. So I was thinking about a very generic pictogram, the same that for the pregnant woman, for instance, just telling the patient, if you experience a drug reaction, or if you experience an adverse event that is listed on your patient leaflet, just stop the drug, go to your doctor immediately. If it's done immediately, and it's absolutely important to, so it's also very important to to educate the patient on that. At the same time, he has to be aware of the fact that there are some adverse reactions, but this is a very general thought about how to explain the adverse reaction to the patient and be sure that after that he's not too afraid to comply to the treatment. So this is something that we have to learn and to practice and to be trained about that. And this is something that we could perhaps try to do in ISOP Israel, to have like a session about how to practice, how to do risk communication. And by the way, we have a working group in ISOP International about risk communication. I belong to this group. So this is something that we could try to train people. What do you think about this idea of the pictogram?
Again, if I may, if we stick to the example you used today, I did not check the numbers, but I am quite sure that many patients on allopurinol will have rash, which not ending up as the tragedy that happened here. So, someone started a new medication, say allopurinol, and had some rash. Is this a reason to stop all of them? Very probably not. Very probably not. I'm a pediatrician. I see every day a lot of kids with rash. Very little percentage of that will continue to something idiosyncratic. So I'm not so sure that it's the pictogram itself. It's what the science that you want to tell people. And the problem, I clearly did not mean to say that rare things are not important. It's just that what do you do if out of 100 people on allopurinol developing some rash, only 0.4% of them will go on what's the message for physicians? I don't know the answer actually, except to tell them the statistics. But in terms of action plan, I'm not so sure that you want them to stop immediately in all 100 cases, because many of them receive it for an indication. So life, as I see it, is much more complex than finding a pictogram.
Yeah. I mean, Gideon, let me expand on that a little bit, and put it into kind of like a COVID-19 situation, especially for a pediatrician. There was a time, maybe a month ago, where all you read about was Kawasaki syndrome. When we're really talking about in the US, a dozen cases, literally a dozen cases. If you didn't read into the 10th paragraph, you'd think that every 5th child with COVID was dying from Kawasaki syndrome. So again, you have to be very careful, kind of from a precautionary principle perspective, not to let one tragedy unduly influence kind of the broader public health discussion.
I totally agree with you, totally agree. And then, yeah.
Okay, so we have to find a balance between the fact that it's very rare, and that we have also to inform, and we have to do something, I think.
Can I suggest possibly a different pictogram that would suggest if this medication doesn't make you feel well, call your doctor, or something to that effect. There's nothing.
Yes.
That would probably be a lot better than stop the medication or throw it out or go to the hospital. But just if you're taking this medication, and I don't know how you put this in some kind of a hieroglyph, or maybe we need to contact a cave artist, but something that would suggest that if this medication is making you feel bad, very generic term for people who may not be educated.
Yes.
Contact your doctor.
Yes. In fact, we have started to make a campaign in Mayana Yoshua. In fact, we have started to have all the documents and the infographics for the patient, to raise the awareness of the patient about the adverse events, and to tell them to be aware that there is a benefit and there is a risk for each drug, and that they have to call immediately their doctor, and to send in a very quick and easy application, which has been translated in Hebrew by Gila, and is available in English and in French and in many languages for Victoria and the people who are coming from US. So we have started to make like a campaign to increase the awareness of the patient. We know that with artificial intelligence, we can retrieve adverse reaction from the electronic medical record, which was the first reaction of Gideon, saying, but we don't have any more to wait for the physician or pharmacist to report cases. Yes. But anyway, I think that it's raising the awareness of the patient if he's doing that. So, do we have any other question? No. So
just another question that I had maybe in terms of policy issue or response issue. If you're going to put a response or a direct or suggest a response by patients if they're having some adverse reaction, whether it's on pictogram or written, who do they, depending on the country, I guess, or the community that's taking care of the patient, some places their first interaction or their most close interaction is with the pharmacist, some places the physician. How do you address that in certain circumstances? Sometimes in Israeli practices, the pharmacist is the one that actually has the most interaction with the patient. And I don't know which is better or which to approach.
I think that this is why we are really, it's very important for us to have an integrated approach and multidisciplinary approach. And we have a partnership with NIDIMED, BMedWise, a US association, which has been funded by FDA about patient education. And they have video and a little booklet for the patient, which are very, very good, and we are allowed to translate this into Hebrew, and it's a way to make campaigns for the patient, toward the patient, and to make a campaign of awareness in pharmacy, and we have had a project in Superfarm, in the hospital, in the community, in the Kupot Cholim. So we have to address all the stakeholders, and it's only if we are we have all these stakeholders working together that we will succeed to be more efficient. Any other question or remark? Okay.
You've done a good job and a wonderful presentation, Irene.
Thank you so much. So have a nice evening or afternoon, and we will wait you for the 15th of July and for the other events of the hot summer in drug safety. Have a nice evening. Bye.